Welcome to the Benzo Free Podcast, your home for an honest, straightforward, and personal discussion about anti-anxiety drugs, their effects, and how to deal with dependence and withdrawal. Whether you have taken benzodiazepines, Z drugs, or any other tranquilizers, know someone who has, or you just want help dealing with chronic anxiety and insomnia, this is your podcast. I'm your host, D.E. Foster, author of the book, Benzo Free, The World of Anti-Anxiety Drugs and the Reality of Withdrawal. I'm so glad you joined us today. Please stick around and let me bend your ear for a few minutes. It just might feel a little better on the other side. Hello there, this is D, and welcome to episode 97 of the Benzo Free Podcast. Episode 97. I honestly have no recollection of doing the first 96. Oh, I can't believe it's been almost 3 years now and we've been doing this for a while. So how are you doing? You know, my hope for you is that today is a good day. Just, sometimes we just want one good day to help us get through the other ones that can eat away at our resilience and eat away at that positive mood we try so hard to maintain but find so difficult to maintain in the midst of benzo withdrawal. So my hope for you today is that today is a good day. A good day. This is part 2 of our 2-part interview with Dr. Alexis Ritvo. If you haven't listened to part 1 yet, please go back and listen to that first. It'll make a lot more sense, I think, if you listen to part 1 first and then listen to part 2. But you know what? You don't have to. You can listen to them in any order you want to, or if you just think the content of part 2 is what you want to hear and not part 1, I get it. Listen to part 2. That is fine. You can find a link to part 2 of this interview. You can find a link to part 1 of this interview because this is part 2. You can find a link to part 1 of this interview in our show notes. Also, part 2 is actually the longest part. Part 1 was shorter, about 30 minutes or so, but part 2 is about 45 minutes, I think, close to that, of the interview. So since this one's longer, our introduction here is going to be much shorter. So I'm not going to talk too much about things here. In fact, I'm going to end it real shortly and just say, I hope you're doing okay. I hope you have that good day. I just hope this ends soon for you. I hope we all can get past this. I hope we all can find some solutions. I hope we all can stop this from happening to people. And I say I hope, meaning I have that hope. I'm seeing signs of this. I'm seeing some solutions. I'm seeing advocacy. I'm seeing awareness being raised. I'm seeing some changes happening. And it's exciting. And we're starting to make a difference. But for those of you in the middle of withdrawal where it just keeps going on and on and on, I get it. It's hard to see that hope. It's hard to see that progress. But it's there, trust me. And things are getting better, and we're doing the best we can to try to make sure that this doesn't keep happening to people over and over again. Our format for today's episode is our introduction, which was brief, and you just heard it. And then our feature is part 2 of our conversation with Dr. Alexis Ritvo. Before we move on, don't forget, I'd love to hear from you. Please comment on our videos on YouTube or on our podcast posts or via our feedback form on our website at easinganxiety.com/feedback. And while you're there, perhaps you might want to subscribe to our mailing list or even donate to support the work we do. Every little bit helps, and those donations really make a big difference for me. And remember, the Benzo Free Podcast is for informational purposes only, and it should never be considered medical advice. Our feature today, as I mentioned, is part 2 of our conversation with Dr. Alexis Ritvo. Even though I read her condensed bio in part 1, I think I should repeat it here too. It's only going to take me about 30 seconds or 45 seconds. But just in case some of you are only turning into part 2, are tuning into part 2 and not into part 1, I think it's good for me to repeat this really quickly here. So, Alexis Ritvo, MD and PH, serves as Medical Director for the Alliance for Benzodiazepine Best Practices. And she is also co-chair for the Benzodiazepine Action Work Group at the Colorado Consortium for I should be able to say this. I say this word all the time since I work for them, but at the Colorado Consortium for Prescription Drug Abuse Prevention, but it still trips me up sometimes. She is a board-certified addiction psychiatrist and assistant professor of psychiatry at the University of Colorado School of Medicine. She has been the program director for the CU Addiction Psychiatry Fellowship since July 2020. Dr. Ritvo has a passion for psychotherapy, teaching, and improving health systems and policies. I'm going to leave it there. There's much more to tell. And if you really want to hear her complete background, please listen to part 1. She gives a wonderful introduction and tells some things about herself, some very interesting things about her lineage in psychiatry and everything. And I think it's interesting, so please go check that out. But now let's move on to part 2 of our conversation with Dr. Ritvo. All right, and welcome back to part 2 of our conversation with Dr. Alexis Ritvo. If you haven't listened to part 1, please do so. You can find it on our website at easinganxiety.com. So, Dr. Alexis Ritvo, welcome back.
Thank you.
In part 1 of this conversation, we talked a lot about advocacy and a lot about organizations and work that's being done to help the patient, to help prescribing, help deprescribing, peer support, and such. I'd like in the second part to move on, since most of our listeners are actual patients, people who are dealing with long-term complications, who are even in the middle of a taper or have completely tapered and still have protracted going on for months or years, and what they're dealing with. And I think it'd be great to now have a conversation kind of geared towards them about, maybe what can we do to help them, or where do they go, or what have we learned about this? So I think one of the things I'd like to start with, if it's okay with you, is the doctor situation. The question that we get most often is, how do I find a doctor? Many people are frustrated with their doctors, either psychiatrists, GPs, whoever's working with them. Some can't seem to find somebody who will help them withdraw. Some tell them to stay on the drugs. Some won't listen to them, don't feel they're being listened to. I know we've worked through different things about talking about, getting with benzo-wise physicians, or even if that's as important as it is just having a doctor who will work with you and listen to you. What's your take on this? What advice might you have? And where do you come from on this topic?
Yeah. I mean, while I wish we were already in a world where all prescribers that are prescribing benzodiazepines were benzo-wise, that's not yet the case. So I think first and foremost is just finding a doctor that you feel like will listen to you and is willing to acknowledge what they don't know. So finding a way, having a doctor that you can provide some resources to say, I realize this is not something that many prescribers have heard. We know there's at least 10 to 15% of patients that really do have this extremely difficult time with benzodiazepines, especially coming off them and prolonged symptoms, and giving them some resources. So I will say the Alliance for Benzodiazepine Best Practices has created some really good tools for talking to your prescriber and trying to provide them some education. I think, even going.
How do they find those? Is that on their website?
Yeah, if they go to let me look it up and I can tell you.
So benzoreform.org is the website URL, and then
and then they are called. My computer's now being a little slow, so give me.
That's okay.
Too much thinking. So when you go to the top, the top kind of information bar has one section that's for patients, and under the patient tools, there's a prescriber information pamphlet. There's a pamphlet communication guide and summary, and a prepare to meet, which I think is like preparing to meet with your prescriber. And all those pamphlets are printable to bring in. The Benzodiazepine Information Coalition also has good resources.
Right.
And then, there are, as well as our consortium, those guidances. maybe want to pick one that you like to start with, but I think telling your prescriber that as you've learned more about this and found these reputable resources, you think that these might be some of the things that are affecting you, and would they be willing to learn more about it and see how they could support you in potentially decreasing these medications in a very, in a safe, effective manner, evaluating the other symptoms that you might be having from these medications.
That's great. One of the stats out there, of course, and it varies depending on the source, anywhere from like 60 to 90% of all benzo prescriptions are provided by a general practice, by a GP. And that seems to be, as a psychiatrist, that seems to be kind of where a lot of do you think that's part of the problem? Is it just a lack of education, since don't have the specialty training that psychiatrists do in some of these drugs? Is that part of the problem?
I don't. So one of the talks I've given, actually, that is posted on the consortium website about lessons we can learn from the opioid epidemic.
Right.
I think there's a big parallel to what we saw with opioids. So I think for a long time, it's touted that benzodiazepines are fairly safe because they were safer than the previous generation of
The
medication.
barbiturates.
Yeah, medication. But it takes time to learn what we don't know. And so I think there just hasn't been, so much, how should I say this? So with opioids, we knew there became a big focus on pain, and it's faster to prescribe a medication than to try to find alternative therapies, get people connected with physical therapy or acupuncture, other modalities. And so that worked really well. And, it took a few years or more for us to realize that there was a fair amount of harm related to these medications. And I think with benzos, I mean, they've been around, been used frequently for longer, but I think there was a period of time where they became even more common. And a lot of it is also a result of our poor mental health system, inadequately funded, inadequately staffed mental health system, people having trouble accessing therapy and other modalities that we know are helpful for anxiety and distress and trauma. And general practitioners are trying to evaluate and treat, everything that a patient presents dealing with. And many patients have heard of these medications, either from friends or family or previously taking them, benzodiazepines, and may ask for them specifically.
Right.
And in a 15-minute follow-up visit, to even try to go through all the potential risks. So I think that's how a lot of this got set up. The psychiatrists do prescribe a fair amount of benzodiazepines. I would say a good portion of them are being continued after they've been started, say by a general practitioner. But overall, over time, there hasn't been a change in the percentage that that psychiatry has been prescribing. There's been a big increase in how much primary care has been prescribing.
Okay.
And I think a lot of that too is, especially in our country, we have this mentality, of you shouldn't be in pain, you shouldn't be anxious, you shouldn't be in distress.
The magic pill. We all want the magic pill.
Yeah, because other developed countries do not prescribe them at the rates we do. And other developed countries like Britain and Australia, which also have very different health systems, but they also have much more clear guidance on prescribing these.
One of the things I hear a lot about is, of course, I deal mostly with people who are in, difficult states and have been harmed and are, many of them have lost jobs, lost relationships, lost so much of their life, who are so focused in the anger and the frustration, and are having trouble moving on to the healing. From a psychiatric point of view, how do you work with somebody that's kind of trapped in that mental state?
Yeah, I mean, I guess I would say in some ways it's like a complex grieving process. Any sort of trauma, it's a trauma of sorts, right? Something that negatively impacts us, feel like we lack control and have been the victim of something. I think a lot of it, there's acceptance, and some of it is allowing yourself to feel a mix of feelings.
Hmm.
One of the terms I often teach patients is the idea of a dialectic. So a dialectic is the idea that you can have two opposing things that coexist, right? So you
Okay.
can be pissed off, angry, hurt, and you can be hopeful, loving, have things that you're excited about, and those two things can coexist. So sometimes if you try too much to ignore what you're feeling that's bad, that can kind of,
Right.
pressure
Right.
cook. So how do you allow yourself those feelings while also allowing and cultivating the feelings that will help you move forward?
And these medications, correct me if I'm wrong, I've also suppressed a lot of those feelings if we've been taking them long term. And the return of those emotions is one of the things I hear so often, and I dealt with too.
Yeah. So yeah, this idea, I mean, one way I've put it is, so as the mother of two young children, toddlers who I'm regularly trying to help deal with their emotions and things that seem very are very upsetting to them. While sometimes I wish I could just take it away because it would make it feel easier, and yeah, I wouldn't have to kind of stay in the thick of it with them. Ultimately, what I hope for as a parent is that I help them learn that how to handle this distress, help them learn that they can tolerate the distress, help them learn how to identify their emotions and how to regulate them, and move through them. And I think what happens with benzodiazepines when used chronically is, yeah, your body and brain has been used to having this medication on board that has dampened
Yeah.
your response to anything that is distressing, but also to potentially feeling the full range of emotions. So maybe not only negative emotions, but also experiencing,
Right.
more
Right.
positive emotions, happiness, excitement, because your nervous system has been under this kind of chronic state of sedation.
Yeah. Even return of libido
Mhm.
is often we've noticed too with many people. So it's just that return of joy and sorrow both
Yeah.
come
And
back.
knowing, um and having the faith that you can handle life's,
Yes.
distress. And I
Yeah.
will say this is where I think having background in working with individuals in addiction is helpful, because that is a big thing that individuals
Right.
also in recovery from addiction struggle with, because they have been used to using a substance, that modifies how they think and feel to exist in daily life, and deal with life's events and stressors, and to suddenly take away that coping skill, even if it has become or is maladaptive or has um, some negative parts, which I think the long-term use of benzos we know does, puts you in a
Yeah.
place where you're really vulnerable, because you have to either learn new coping skills or have to go back and bring out ones that you haven't used in a while.
Exactly. Like Ashton mentioned the learning deficit, which I bring up a lot, and I know
Yes.
we've talked about before, which it really, that's part of the problem is, we're the medication, in my opinion, has helped us manage our emotions for so long, and now we no longer have that quote unquote benefit. And now we have to learn those skills, those tools for managing anxiety and stress that we may have let atrophy over time because we didn't, a pill was doing it for us.
Yeah. Yeah. And realizing, and building that self-confidence again, that you can handle this.
Right.
I will
That
get
makes
through
sense. That
this.
makes
This
sense.
too shall pass. Like, because when you haven't, then smaller things, yeah, feel really overwhelming. And like I said, I see this in my toddlers all the time. Some of the
Yeah.
things that get them really upset because they don't know yet. Like, it's okay. Like, that's out of my control. And while it's upsetting, things are going to be okay.
I really love the self-confidence piece. I didn't really think of it from that standpoint, but I think you have an excellent point of, knowing that you can get through this, knowing that you can handle this, knowing that you can handle these emotions are definitely things I see people struggling with when they're coming off of benzos. And I think that's an excellent point. One of the things on that about mindset too that I noticed when I was going in, when I found out I was dependent on clonazepam after 12 years, I decided to go back to my original doctor who wanted me to stay on it. So I went back to a previous doctor who was still fine with me staying on it, but would work with me. And he was a doctor I trusted, so he was the one I wanted to work with. The first thing he did was say, I want you to wait 6 months. He did not want me to start to taper for 6 months because, and quote unquote, he said, I don't have the right mindset. Now, of course, I then since then have written about quote unquote the mindset in my book, and I've talked about it on the podcast many times, but I think you might understand this and maybe can elaborate on it. I wasn't mentally stable at the time I first went to that doctor, and he saw that in me. And I think it was one of the smartest things ever done was that my doctor said, I want you to wait 6 months before you start the taper. Can you comment on that?
Yeah, I mean, I think we see this in psychiatry all the time. Whether it's someone suffering from depression that's been on antidepressants, or I deal with this in substance use disorder, say an individual that's in recovery from alcohol and has been on a medication for addiction treatment that is helping with cravings, and they don't want to be on it long term. In both of those cases, what I'll tell people is, I mean, one, unfortunately, because of the complexities of studying these things, we don't have great research. But what we know the best thing we can do to improve someone's outcomes is to try to make sure at the time that we start to taper these medications, that we do it when the patient's at their most stable and their risk factors for return of symptoms or return in substance use, return to substance use, return of depression is lower and their protective factors are higher. And so I'll talk to patients about that and say, I mean, and usually that you want symptoms to be stable somewhere. Yeah. And that, I mean, again, we don't have great research, but 6 months to a year, depending on what the circumstances are. I tell people we don't want to make start these changes when you're changing jobs, moving, going through a divorce,
Right.
have, someone in a family that's ill. Like, these would all be things that it might be better to keep things where they are. Granted, everyone has different circumstances and different desires, but just keeping in mind that those those kind of events are going to make it more challenging, because that's when you need a reserve of coping skills and confidence in your ability to get through things.
Triggers get escalated so severely at that stage, and it's nice. I know a lot of people can't always manage that or have that availability to isolate some of the their stressors in their life, but it's great to be able to do that at least for a short term while you're so heightened, at least in my opinion. So that does seem to be a factor that people deal with.
Yeah, and I think if depending on the resources available to someone, their insurance, and of course, I mean, just in our mental health crisis coming in amidst this pandemic, just lack of providers. But if someone's able to, first and foremost, I'm a huge proponent of therapy. So if someone's able to get into psychotherapy and have someone that they're meeting with regularly, ideally at least weekly, or at the very least every other week, to just have someone outside of their usual circle that they can process what they're experiencing and that can help them hold some of these distressing experiences that they're going through is invaluable. So I think if they're able to do that, great. If they also have other, if they have more moderate to severe depression or other mental health issues going on, getting an evaluation to determine if other medications could be helpful in addition to psychotherapy. I, understand that patients are going to be, many patients will be reluctant to add something else when they're trying to get off a medication they see as harmful. But I think finding a provider that you feel like you trust and can have this discussion of the potential risk benefit of each choice.
Right. Yeah. In fact, I just had one of my listeners just contacted me saying, I think I need some additional medication. And of course, my first thing to it is, well, I can't advise you on that. And then my second thing is, I went through that. I had a couple SSRIs I tried out along the process. I don't think they benefited me very much, but for some people they do. And I know Ashton even talks about that in her manual about this. That's one of the few supplements that can help, sometimes antidepressants and stuff like that, through this process, because it's a very difficult process for some people.
Yeah.
As we know, not for all people, but for some people, it's very difficult, and we might need some help. How about non-medication options? I don't know if you ever get into this or ever have dealt with this with some patients through like benzo withdrawal. Have you heard of that? What's your take on that?
I mean, to me, as long as, again, it's all a risk benefit. So most things like
Right.
I mean, certainly psychotherapy is helpful, and depending on what someone's dealing with in their life, what, there's different modalities, with different evidence for different symptoms. But I
Hmm.
certainly think, since a lot of this most people are taking a benzo usually for anxiety and or insomnia. So doing things that have good evidence for helping with those. So for short
Okay.
term, for building some skills, things like cognitive behavioral therapy for insomnia is actually gold standard. It has better effects than medications for sleep. So seeking out, a group if you can. If not, there's a lot of great online resources for what you'll hear as CBTI, so cognitive behavioral therapy for insomnia. Same cognitive behavioral therapy, especially with mindfulness based relaxation. So mindfulness, I think, is
Yeah, I found that in counseling for me were probably two of my keys, were
yeah,
mindfulness
and it
and
takes practice.
yeah, it does, absolutely, and I'm not great at it, but I try to stick with it.
Right. I mean, it is a practice. So you don't, trying to learn these skills and practice them not just when you're feeling extremely stressed and anxious. We had there are some people do really well with the apps out there, and like the apps like Calm or
Yeah, the
Headspace.
Calm and Headspace, and yeah, some of those are
And
excellent.
actually, I will
Yeah.
say the VA, the Veterans Administration, puts out a
Uh-huh.
lot of great free apps.
Oh, that's good.
So they have one for cognitive behavioral therapy. They have one that they created and modified during COVID. I can come up with a name that has some mindfulness
Yeah,
apps.
that would be interesting.
Um, the Just YouTube, on YouTube you can find great like
Yeah.
mindfulness um, uh, music to listen to as you're going to sleep with diurnal beats that actually has some evidence
Uh-huh.
as far as
I
the brain waves it taps into. I personally have trouble doing mindfulness that's not active in some way. Um,
Okay, I
so
understand
I
that.
like progressive muscle relaxation, and
Yeah.
you can find guided meditations with that, just because at least you're physically doing something. One of the quick skills that I like to teach people,
Uh-huh.
I don't know, have you heard about the mammalian diving reflex?
I have actually, yeah, a long time ago, but I do
Yeah.
remember that.
So for especially patients that have been that suffer from panic or feel like when they
Mhm.
get really distressed, that fight or flight of their nervous system kicks in, and they have trouble breathing because they're breathing too fast and heart's racing. So this works faster than any benzodiazepine, and that is you have a nerve, a branch of a nerve that runs
Mhm.
under your eye, and it has a temperature sensor. And in mammals, one thing that temperature sensor does is when it um, gets cold and the breath is being held, like so diving into cold water is how it
Right.
gets sensed. It tells your body to slow down your breathing and slow down your heart rate to conserve energy and keep your core warm. And so you can trigger that the most realistic way, although I don't love it, but is you can get a bowl of cold water and stick your face in it. The other way is holding your breath and putting like a bag of like a Ziploc bag with ice water across that skin under your eyes. And for like 30 seconds, 20, whatever you can hold your breath for, taking some really good deep breaths. And there's some good videos online of, a guy that I think he was a psychologist, but suffers from panic attacks. And he shows on his smartwatch, his heart rate going down pretty quickly using
Right.
that trick. So,
That is so interesting. It's funny because when you said that, I said, "Well, yeah, I'm familiar with it," but not at all in the context you're saying. I actually used to teach lifeguard training
oh, okay.
for about 10 years, and we studied mammalian diving reflex because of, preserving temperature and stuff and that reaction to water and survival. So, it's funny, I never thought about it from the psychological standpoint, and this is really interesting, you
Yeah.
know?
And I think it's a really good mindfulness skill. I mean, so, mindfulness talks about non-judgmental awareness. So how do you cultivate awareness without judgment of what you're feeling, thinking, they talk about
Right,
using all your
right.
senses. Um, and so I think for a lot of people too, that change in temperature and sensation can be helpful to kind of remove you a little bit from whatever is acutely overwhelming you. So I think looking at things like that, there's so many resources now. Often, of course, I think social connection is such an important piece in support.
Mhm.
Um, and so finding people that are dealing with similar things
Right.
online is great, but if possible, locally, because I think that the importance of not dealing with things alone is such a big part of learning to handle distress.
Yeah.
Um,
Exactly. Exactly. A topic that came up when I was listening to you was polydrugging. It's a term I know we use. I don't know if it's really used in the medical community as much, but we use it a lot in the benzo community.
Mhm.
We have a mutual friend, and I can say his name because his story has been public, which is John State, and he currently is in that, and he shared his story on some live podcast or some live events we've done. And he currently is in that state. He's on a benzo or two, along with some other psych drugs, and he's not the only one. There's so many people that I speak with sometimes who are on multiple medications and either aren't getting the support from their psychiatrist or doctor that they're looking for, or that doctor is telling them to stay on them,
Mhm.
and not do anything. For the patient who is on multiple medication and is fearful of long-term complications from benzos and possibly from these other meds, how do they approach their psychiatrist? Do you have any advice for them about how to go about it, especially when they don't even know with their symptoms which drug is causing the problem?
Yeah,
Or if they wanted to start taper, which one do they start to taper?
yeah.
Is there any information you can provide in that area?
I think, if you're able to ask your prescriber to sit down with you, or in writing, talk with you through, we
Hmm.
talk about what this medication's for, what does it help with, and how does it work, and what are the most common side effects. I frequently use one of our databases called Micromedics, which reports adverse side effects by what's reported in the literature. So it has to have been reported, which we know that means this stuff is missed, but at least gives you a percentage of, in trials, this is the percentage of people. And sometimes it can be a very wide range, but that report insomnia or agitation or dry mouth or what have you, and kind of look at those things and think through, which might be the most likely to be contributing to some of the side effects. Um,
Okay.
as well as what does the med do, and is it currently helping with the depression or sleep or anxiety, and also what are the potential risks or side effects with decreasing
Okay.
each med. The most important thing, and I'm sure my patients are sick of hearing me say this, but is I always tell my patients, my goal is we do not want to make you a bad science experiment. So we do not want to change
Right.
multiple things at once.
Okay.
Because if we make multiple changes, starting, decreasing, stopping medications, and you have a side effect or a withdrawal symptom or anything like that, we won't know which medication's causing it. I mean, sometimes you can know if they're very different mechanisms, and sometimes you don't have the liberty, but most of the time, if you
Yeah.
can not make multiple changes, it's to your
Okay.
benefit. So that would be, first and foremost, and then thinking through which one you might choose to work on decreasing first.
Say hypothetically, I know you can't. I know you can't. I know you can't provide any medical advice here on the show. But just say hypothetically, somebody's on a benzo and an SSRI, or is on that or a psychotropic or something like that, and they're just deciding. You know, some of the literature says that they should go ahead and stay on the SSRI while they're coming off the benzo because that provides some stability. Um, is that what you're seeing most of the time, or
Yeah, I mean, assuming they have a longstanding anxiety or a depression,
okay?
and the fact that tapering the benzos can very likely destabilize that or cause rebound anxiety or insomnia. I think so. I mean, now if it's clear they're having some really bad side effects from the antidepressant, might they work to switch to a different one with fewer side effects? That might be an option.
Okay.
Ultimately, depending on I mean, I try to, work with the patient to discuss through these things and usually tell them here are the few options. One is to always at that time do nothing or change nothing, and wait. And then I always say I'd rather, assuming there's not something that is forcing us to do it much more like rapidly, or we have for some reason limited time, I'd much rather make the smallest decrease we can, given whatever the
Hmm.
formulation of the medication is, to see how they do with it, especially if it's someone that we know has historically had greater sensitivity to medications, and the side effects probably related to how they metabolize the medications, something about their,
Okay.
genetics and how it affects their um, uh, liver metabolism, or something about their nervous system. I mean, it could be for a variety of reasons that we can't often pinpoint, but I'd rather make a small decrease initially, have them
Right.
less likely to have bad symptoms, have them experience what that feels like, and move through it, than make too big of a jump, or and have them
Okay.
have debilitating symptoms and then become both physically and psychologically really
Right. Right.
worried about any further changes.
Yeah, that makes sense. And of course, I do want to just say to everybody, of course, nothing on this show is medical advice, as you all know from either one of us. And also, please work directly with your doctor or psychiatrist if you just choose to withdraw from benzodiazepines. That's something we always say on the show, and I want to make sure
Yeah.
we emphasize that whenever we can. Let's talk about benzodiazepines, the drug, for a second. I know I asked this question when Steve was on, Dr. Stephen Wright. What are the benzos still good for? What would you, as a psychiatrist, or do you think that what should these drugs still be prescribed for? What are they still effective for?
So they're effective in really acute states that need
Okay.
rapid sedation or agitation. So I'll say in the emergency room, psychiatric emergency room, they're used
Right.
frequently.
Right.
So people that come in with an agitation and they're also manic or psychotic, or even in under the influence of drugs like especially methamphetamine, they are
Okay.
very useful.
Because they can instantly calm somebody down, right? That's what they're used
Yeah.
for in like an ER setting. Okay.
Mhm. Especially, and you can, I mean, if needed, you can also give them IV, so you can really deliver them quickly, and done usually in combination with other medications. They're
Okay.
useful if someone's having a seizure to stop a seizure. They're useful for
Right.
alcohol withdrawal. They um, they are useful in really acute, and I'll say individuals that are dealing with, say, a bipolar mood disorder and are becoming manic,
Okay.
and really, like, in addition to using the other medications that help stabilize their mood, needing to get them sleep to try to stop the
Yeah.
manic episode from developing, using a short course, like we're talking, usually
Right.
5 days a week. I mean, certainly less than that, 4 weeks, to get them out, to get their sleep stabilized, can be
Okay.
really helpful. I mean, acute panic attacks while waiting for other medications, like, unfortunately, the antidepressants that can work really well for preventing panic disorder, take some time to work. They take often
Okay.
4 to 6
Yeah.
weeks, at least the SSRIs, SNRIs. And so using them for a few weeks just to help in those instances while putting other things in place. I mean, those medications, psychotherapy, some other coping skills.
Like a bridge drug.
Yeah. And having that very explicit conversation with a patient about it's so important these are used short term, um,
Short term. Great. Yeah.
and that the risk really increases the longer they're used,
Yeah.
that the physical dependence will develop, and then they'll need to be tapered. And then, if they stop suddenly, there's other problems. So I think, and some severe situational anxiety, like
Mhm.
debilitating fear of flying or other phobias where someone really hasn't gotten anything else that makes it possible. I mean, those are things to consider while also weighing all the other risks and benefits, the other things going on in their
Right.
in their life, and of course trying to see if there's alternatives. But I think it is important that I don't think it's helpful for us to just say there's never any use for them, because there are some and they can be used safely. And certainly, my other worry with doing that is then you end up in the situation that happened with opioids, where the pendulum swings
Exactly.
so
Yeah.
far the other way that even people then who have been on them chronically, physicians become leery of the risk, and then too quickly take them off or stop them, or don't want to continue prescribing them at.
We saw that in Ireland. I know not too long ago, Ireland had that where they really cut down strictly on it, but then we had all these people that needed them to taper or, to come off slowly, and they had no access,
Yeah.
and it became a severe problem. They kind of learned that lesson. I'm hoping we learned from them
Mhm.
as to not how not to go about this. One of the
Yeah.
concerns I know many of us in the community are focused on is making sure if we reduce the prescribing of benzos that we don't eliminate the option for people who are tapering or working on coming out from accessing the drugs when they need them.
Yeah, and letting some, I mean, I think there is always the need. On the one hand, I don't think people should be told they have to stay on them, but I also think there are some people that they have to work with their provider and weigh for themselves what risk versus benefit of
Right.
tapering are they able or willing to take. At what point, if they feel like decreasing is too
Yeah.
destabilizing, do they stay on? And I always tell patients, one, it's a marathon, not a sprint, and two, like,
Yeah.
if we need to pause, or even if while it'd be great if we can eventually get them completely off, even getting them on less helps
Yeah.
because it comes with fewer risks.
Right. Right. That makes a lot of sense. Real quick, I want to touch on this, and then we can start to close things down. But I have 18,000 more questions. This is going great. Thank you so
Yeah.
much. But on the science of benzos, what do we know from the research standpoint? We talk a lot about. I know there's been some science on GABA A receptors and the downregulation of those receptors, and we talk about the central nervous system. We talk the peripheral nervous system. We talked. I mean, even Stephen has talked about the mitochondria. From your take and what you've done on research, what do we know about the actual physical changes that have happened based on these drugs? What are we trying to correct?
One, I don't have yet the encyclopedic memory that
Yeah.
Dr. Stephen Wright has of all of the research that's been done. So I say this is an
Right.
area where I'm still very much learning. He's literally been sending me all of his references, and I think it might take
Yeah.
me a lifetime to read them. But I think, one, I think there's a lot we don't know about exactly why certain people, especially, are so sensitive to this, injury, neurotoxicity
Hmm.
that can come from benzos. Was talking to some of my colleagues, and I think you were on these emails as we're talking about the naming, about also what
Yeah.
this mechanism could be, how it might be similar to the mechanism of who is really acutely sensitive to alcohol withdrawal. Even
Hmm.
though benzos do act slightly differently on the GABA receptor than
Right.
alcohol. Um, so, there's some of the issue is, yeah, you get when chronically exposed to benzos, you do get some downregulation of your GABA receptors. I pulled up a slide from one of the talks I given, but from an article that I really like, which is more focused on the issue of use disorder, and using the old term benzodiazepine dependence when that was connected to
Yeah.
addiction. Part of the issue is that so benzos are acting in the spinal cord, and that's related to muscle relaxation, your brain stem, and your cerebellum, and that's why you can get this
Okay.
ataxia, or kind of unsteadiness.
Right.
And then your limbic and cortical areas, and that's where it's involved in emotional expression, experience, in your behavior.
Okay.
And then you also get further downstream changes. It starts affecting other neurotransmitters as well. I mean, so all these things are related. So,
Right.
chronic exposure to this GABA agonism, but GABA,
Yeah.
as you know, this, and it's amazing. This still, like, I have to always think through this, actually inhibits your nervous system. So if you're chronically inhibited, then part of what happened is
Right.
the glutamate, which is your activating, kind of counters GABA, gets riled
Okay.
up underneath. That's why if you stop benzos or alcohol suddenly, which have been causing this chronic depression via GABA of your nervous system, underneath glutamate's really active, trying to make sure you're staying
Hmm.
alert, awake, breathing. And if you take away that inhibition too quickly, that's why you are at risk of seizures, but also a lot of other, I mean, increased anxiety, shakiness, tremor. I haven't seen a lot of really good research that shows exactly what the chronic exposure
Okay.
does.
We're still lacking a lot of that.
We know more from alcohol. Um,
Right.
and again, it acts on the same receptor, but not the same way.
In some of the conversations we've had with the other addiction psychiatrists in our meetings, I know that's come up a few times, and alcohol is always brought up by them because there are similar mechanisms in place and similar effects in place,
Mm-hmm.
between alcohol and benzodiazepines. And that's one of the things we talk a lot about on the podcast too. We've touched on it in the past on alcohol because, should you drink, while on benzos? And that's, well, it actually warns against that on the label, but also especially during withdrawal, because alcohol is affecting those same receptors.
Yeah. I mean, the truth is, yeah, when you combine them, so benzos alone don't tend to cause a dangerous amount of respiratory depression, decreased breathing.
Right.
But when you combine them with alcohol or, of course, with opioids, it becomes very dangerous, and it's just that extreme amount of sedation. But yeah, we have such a huge need for more research, and I think part of this is why we need so much more attention called to what these debilitating long-term effects are. And then also to the fact, I think it's not often enough that the medical community learns about deaths and especially, unfortunately, suicides that are
Right.
connected to suffering from these medications. Because I think you're often told things like, the worry that came with opioids is that, of course, there's a lot of overdoses associated with
Right.
it, and they're deadly. And of course, we know, or some of the literature says, that at least a third of opioid overdose do involve benzos. So I think
Mm-hmm.
there is an acute issue, and I think and we know increasingly that there sadly is a lot of suicide related to the harm from these medications.
Yeah,
And
we've
I
seen
think
that.
those are the stories that are ultimately going to help create more both legislation as well as more guidelines around and research dollars.
In fact, I think that was what was really behind the Benzodiazepine Action Work Group getting recognized by CDPHE, because it was the suicidality, the suicide research that was done in correlation with it that got their attention, because our governor was really focused on reducing suicide within the state. And so that connected, and that got, I think, attention to this cause more than it might not have without that factor.
Yeah.
So sometimes we unfortunately have to use sad statistics like that to get attention for what we're trying to deal with.
Mm-hmm. Absolutely.
So, oh, I could go on and on and on, but I think we probably need to start to close things down, Alexis. I was wondering if you wanted to take a couple minutes here to say any closing words or any advice or reassurances you have for people who are struggling with this and trying to figure out how to handle their taper or come off of benzodiazepines.
Ooh, I mean,
Did I
again,
catch you on that one?
yeah, well, there's so many ways to say. I mean, one is, wanting to apologize, though that doesn't feel adequate, for what patients have endured and experienced as a result of
Mhm.
a prescribed medication. And that I like to think the vast majority of prescribers were trying to help
Right.
and decrease distress and difficulty, and the reason we need to bring so much more awareness. And then I think the other is um how we continue to help educate prescribers how to deal with this and understand why it can be so difficult for patients. I mean, and I'm regularly, when I'm supervising residents, helping them with this, of like, a patient can tell you they recognize X, Y, and Z long-term effect that they think's related, and their goal is ultimately to get off this medication, and
Right.
they're scared, they're anxious, they're worried.
Yeah.
They're worried they're going to become dysfunctional, not be able to work or provide or
Mhm.
caretake. And that might make them ambivalent or reluctant to make a decrease or try to come off or be prescribed fewer, pills next month. And that doesn't mean they don't, they're not, that doesn't mean they don't, like, it's not still their goal. And, how do we just keep in mind that we're on the same team, we have the same goal. And
Right.
and again, I think, it is always to our benefit when possible to go slower, make a smaller increase, or if put some other supports in place before starting, whatever it is, to make sure that a patient feels more confident, supported, comfortable with the plan.
Yeah, that's great. I know it's such a complex problem as we're learning, just as we're working on naming this and everything else and trying to figure out there's so many factors that go into, and that's, I think, part of course the hidden nature of it is that most doctors never recognize the symptoms as being related. I had a conversation with a couple of the Vanderbilt doctors not too long ago, and one of the things he mentioned was when we identified in one of the research papers that certain symptoms were the early on ones and other symptoms were much longer. And we started to realize that those were the same symptoms that doctors are told to watch for are the early ones, not the later ones, especially the cognitive and other dysfunctions and anxiety. And so that's part of the reason why I think a lot of psychiatrists and doctors did not see the these other symptoms, because they weren't taught to look for them. We're looking for the seizures, we're looking for the hallucinations, you're looking for the tremors, the initial ones, but those are normally short-lived. Even in people with long-term benzodiazepines, those usually don't last too long. And so I thought that was interesting, when we started to find some of that. But I think that comes back to your point of, making sure that we educate doctors, psychiatrists, everybody in, hey, this is real, this dependence happens, what to look for, how to help people who want to come off of them, and how to limit the prescribing.
Agreed. A lot of work ahead of us.
A lot of work, but we're doing good work. And I just want to thank you, number one, for being on the show today. This has been amazing. A lot of great information, and I can't wait to have you back. Hopefully you will come back on the show again, because there's much more we can talk about. But also just all the work you've done, and that as a psychiatrist, to take on the extra work of advocacy and educating and everything about this cause. This is what we need in the community, and we are truly grateful to people like yourselves who are taking a lead in helping to change the situation.
Well, thank you. Well, I just feel lucky to have found you all to collaborate with and work together on this issue that is certainly not going away, and hopefully get some people some more relief and keep more people from ending up in this situation.
Great. Well, thank you so much. And thanks for being on the show, Alexis. I really appreciate it. You have a good day.
You too.
Oh, I just want to give a huge thank you to Dr. Ritvo for taking the time out of her incredibly busy schedule to talk with us today. Thanks, Alexis. She is one of the good ones, and I am very grateful that she took her time out to talk with us, and also to be able to work with her every week. She has dedicated her time to this cause. She is spending a lot of time in helping to raise awareness, educating providers, and helping us find a solution for this. And for those medical professionals who are doing that, especially the ones who have never even been through it themselves, but have seen the damage that long-term use of these drugs can do, and have decided to do something about it, like Dr. Stephen Wright, and like so many other addiction psychiatrists and medical doctors that I am now working with, like Dr. Christy Huff, and the list goes on, and I'm not going to list ones, but Nicole Lamberson, physician assistant over at Benzodiazepine Information Coalition. These people are just amazing, and some of them had lived experience, some of them don't, but having that medical knowledge, then being able to work with people in the medical communities to help change the way the medical professional community deals with these drugs makes a huge difference. So I just want to say thanks to Alexis for speaking with us today, and for all that she does. And before I close, please allow me just 25 seconds for our disclaimer. This podcast is for informational purposes only and should not be considered medical advice in any way. The host of this podcast is not a medical professional, nor is he engaged in rendering medical, health, or psychological advice, nor any other kind of personal or professional services. The views and opinions expressed by our listeners and interview guests on this podcast, whether read from textual submissions or presented in their own voice, do not necessarily reflect those of the Benzo Free podcast or of its host. Withdrawal, tapering, or any other change in dosage of benzodiazepines, non-benzodiazepines, or any other prescription drug should only be done under the direct supervision of a licensed physician. Our full disclaimer can be viewed on our website at benzofree.org/disclaimer. And thank you again for joining me for this special conversation. And please, let us know how we did. I'd love to hear from you. Keep calm, taper slowly, and take care of yourself. I'll see you next time.